2020, international gynecologic societies came together to publish a series of recommendations on the practical aspects of different surgical procedures for the treatment of endometriosis. A routine approach allows surgeons to perform systematic surgery in challenging situations where pelvic anatomy is grossly distorted. Endometriosis presents as three different entities: peritoneal lesions, deep endometriosis, and ovarian endometriomas. In this video, we focus on evidence-based treatment of peritoneal and deep disease. First, we consider the evidence behind approaches to the treatment of peritoneal disease. These include focused excision, complete pelvic peritonectomy, and superficial ablation. Each method has advantages and disadvantages. Focused excision of visualized disease may be more efficient and confer decreased surgical risk as fewer structures must be dissected. However, it relies on a surgeon's visual diagnosis, and microscopic disease may be left behind. Peritonectomy allows for histopathologic diagnosis of occult microscopic endometriosis. It has also been demonstrated to improve pain and quality of life in patients with chronic pelvic pain with and without surgical evidence of endometriosis. However, it may confer increased surgical risk and prolong operative time. Peritoneal disease can also be ablated. Based on a 2021 systematic review and meta-analysis, ablation of superficial disease improves dysmenorrhea and dyspareunia, although comparative data is lacking. Ablation is efficient and allows for treatment in areas that are more difficult to resect, such as the diaphragm. Ablation does not allow us to understand the depth of disease, poses a risk of injury to underlying structures which have not been isolated, and does not allow for histopathologic diagnosis. In this focal excision, the lesion in the anterior compartment is visually identified. The paravesical space is opened laterally and the peritoneum is thinned out. The location of the lesion is confirmed and the peritoneum is resected, ensuring a margin is obtained. When performing a pelvic sidewall peritonectomy, first the peritoneum is opened at the pelvic brim at the base of the IP vessels above the level of the ureter. The pararectal space is opened and the incision is extended, confirming ureter location along the way. The incision is extended to include the ovarian fossa and is carried medially towards the uterosacral ligament. The ureter is identified vermiculating in the pararectal space and is lateralized off of the peritoneum. The hypogastric nerve, which lies medial and dorsal to the ureter in the medial pararectal space, is also identified and lateralized to ensure a nerve-sparing procedure. Starting cranially, the peritoneum is completely excised. Now we will review an evidence-based surgical approach to the excision of deep endometriosis. At the beginning of the procedure, the pelvis should be systematically prepared. The following evidence-based steps should be used. First, the sigmoid should be mobilized. Starting from the white line of Tolt, physiologic adhesions are lysed to mobilize the sigmoid and its attachments to the abdominal wall and pelvic sidewall. Efforts should be made to avoid entering the retroperitoneum during this step. This exposes the left adnexa, pararectal space, and ovarian fossa. Next, fixed ovaries are mobilized off of medial structures and off of the pelvic sidewall to improve the view of the operative field. Ovariolysis is preferentially done bluntly, although sharp dissection and electrosurgery may be needed. If the ovary is densely adherent to the sidewall, the pararectal space may first be opened and ureterolysis performed to delineate the ureter's location prior to mobilizing with electrosurgery. It is key to divide adhesions and restore pelvic anatomy in addition to completely excising endometriosis. We then perform ureterolysis. The ureter can be reliably identified in the pararectal space with ureteric vermiculation. Here, a medial approach to the pararectal space is employed. Starting at the pelvic brim in healthy tissue, the ureter is isolated and dissected off the pelvic sidewall peritoneum. Complete ureterolysis should be performed to the anterior division of the internal iliac artery or ureteric canal. Next, we will illustrate evidence-based steps to follow when approaching deep endometriosis of the rectovaginal septum as outlined in consensus recommendations. Access to the rectovaginal septum is often hindered by dense adhesions between the rectum, uterosacral ligaments, and the dorsal uterus. Complete dissection of these adhesions is necessary. The perirectal space should be entered in healthy tissue that is free of adhesions. The space is opened longitudinally, medially from the uterosacral ligaments and as close to the lateral side of the bowel as possible in order to avoid injury to the hypogastric nerves. Now the aim is to mobilize the ventral rectal wall from the rectovaginal septal nodule. Placement of a uterine manipulator, such as the Valcheb device, allows for palpation of the lateral rectovaginal septum. Working from lateral to medial, a plane is developed in healthy tissue. Now the borders of the rectum can be identified. The rectum is shaved off of the vagina by dividing the nodule. This is done by mechanical dissection using cold scissors. The rectum falls dorsally and healthy vaginal tissue can be palpated. The cul-de-sac is now visualized. The nodule is then shaved off the bowel serosa. Bowel wall integrity is confirmed with rigid sigmoidoscopy, ensuring no bubbles are seen. Using latest guideline evidence, we present an overarching approach to surgical treatment of superficial and deep endometriosis. Superficial endometriosis can be managed with focal excision, peritonectomy, or ablation. There are pros and cons to consider when choosing a method of treatment. When approaching deep disease, the pelvis should first be prepared with enterolysis, ovariolysis, and ureterolysis. Deep endometriosis of the rectovaginal septum should be systematically approached using 4 key steps. Thank you.